Today I will talk about pediatric hip and femoral shaft fractures. What about the incidence of pediatric hip fractures? It is very rare compared to other injuries. It accounts for less than 1% of all pediatric fractures. Regarding the anatomy, the proximal femoral epiphysis is a single physis at birth. It started to divide at age of 4 years to two separate growth centers, one of the femoral head and the other at the greater trochanter. Mechanism of injury is usually associated with high energy trauma. It accounts about 30% of cases. We should search for other associated injuries like intra-abdominal or intra-pelvic or other visceral injuries or head injuries. If the mechanism of trauma is minor trauma or there is a repeated form of fractures, you should search for pathological conditions or pathological fractures. The classification of the proximal femoral fractures or the pelvic hip or the pelvic fractures or fractures in pediatrics, usually we use the Dilbert classification. This is type 1 fractures is the transphyseal fractures. It's like Sutter-Harris type 1. Type 2 fractures is a transcervical fractures. It is the most common fracture type. Type 3 is the cervicotrochanteric or the basicervical fractures. Type 4 is the intertrochanteric or ptertrochanteric fractures. Type 1 is a transcervical. This is like type 1 physeal injury of Sutter-Harris. We should differentiate this type from slipped capital femoral epiphysis, the chronic cases. How to differentiate these fractures by the slipped capital femoral epiphysis? Usually it occurs in a younger age group, usually below 9 years old. Usually there is a history of sudden onset severe pain, and usually there is a history of severe trauma. And on the X-ray, there is a more displacement of acute separation of the physis. This is X-ray of a 10 years old child with transphyseal or type 1 fractures with the posterior dislocation of the epiphysis. Type 2 is the most common type of pediatric hip fractures. It is a transcervical. It accounts about 50% of cases. And unfortunately, it is associated with higher incidence of AVN, about 50% of cases of AVN. And the most predicator of AVN is the displacement of the fracture at the time of injury. Type 3 is the cervicotrochanteric or the basicervical fractures. It is lesser in incidence, about 20, 25, or 20 or 35 of cases, and the AVN is approximately 20 to 25 of cases. Type 4 is the ptertrochanteric or intertrochanteric fractures. It is lesser in incidence, the least of incidence, about 6% to 15%, and the AVN is lesser than 10%. And this type of fractures have the best overall outcome. Clinical features of the pediatric hip fractures: you should take a good history regarding the mechanism of injury. You should ask about what about the site of pain, and usually the child cannot give a good description of other painful areas, so you should search for other associated injuries. On physical examination, the limb, the fractured limb is externally rotated, slightly adducted, and the limb appears short. The patient is in severe pain, unable to move the limb actively. If there is a dislocation, the extremity held in flexion, adduction, and internal rotation. By examination, there is local tenderness, usually on the femoral neck, and passive motion of the extremity is markedly restricted, especially with flexion, abduction, and internal rotation. The goal of treatment of children hip fractures are to achieve anatomical reduction and provide stability to the fracture fragment to maintain the reduction and allow complete fracture healing. Most of these fractures treated by closed reduction of the fractures and internal fixation, either by threaded K wires or cannulated screws in older children. The closed reduction maneuver consists of, first of all, we start by full abduction of the normal hip to stabilize the pelvis, followed by slowly flexing the fractured hip and slightly abduction and internal rotation, while the surgeon observes the fracture under fluoroscopy. Once radiographic reduction is achieved, internal fixation should be performed. This is showing the closed reduction maneuver. First, we start by simple flexion of the fractured hip, followed by gentle traction, abduction, and internal rotation. Once the fracture stability is achieved under the fluoroscopy, fixation is started. This is X-ray showing the previously shown case of type 1 fracture or Salter-Harris type 1 with transdiaphyseal fractures. It is managed by closed reduction and internal fixation by cannulated screws. But unfortunately, after 4 years follow-up, there is an incidence or there is an AVN shown here, and with prominence of the femoral of the cannulated screws and collapse of the femoral head, as we see here. The internal fixation devices or the screws should kept distal to the fibers so as not to injure the physeal growth plate and not result up in growth arrest. However, the fracture stability of prime importance and should not be compromised in an attempt to avoid the growth plate. If closed manipulation failed to achieve anatomical reduction, open reduction, either through an anterior or anterolateral approach must be performed. What about the complications associated with pediatric hip fractures? The most common complication and the most devastating complication is the AVN. And the most predisposing factors for AVN is the fracture displacement at the type of fractures, at the type of initial trauma. This is the most important predisposing factors. Usually it is most common in type 1 and type 2 fractures, and usually it is common in older children above 12 years old. The second common complication is coxa-vara. Usually coxa-vara is a result of malreduction of the fracture or loss of reduction because of inadequate fracture stabilization. Like we see here, this is a 10 years old girl with cervicotrochanteric fractures. The fracture line is vertical and it's fixed by 2 cannulated screws. But unfortunately, with the follow-up, it results up with cutting out of the metaphysis of the screws and result in a coxa-vara. This is managed by subtrochanteric valgus osteotomy to correct the coxa-vara and result up with good union. Third common complication is a non-union, and this is X-ray showing non-union of the fractured neck femur fixed by cannulated screws and threaded key wires, result up with non-union here. So valgus osteotomy was performed to promote fracture healing, as we see here, with good union also. The second topic is the femoral shaft fractures. What about the mechanism of injury? Usually, we should consider child abuse if the fracture below the age of 4 years. The most common form is a child abuse. So you should take a good history to exclude this method of injury. In adolescent age groups, high velocity motor vehicle accidents, this is the most common form of mechanism of injury that account more than 90% of all femoral shaft fractures. However, if there is a minor trauma or repeated fractures, we should take in consideration the pathological conditions. Classifications of femoral shaft fractures, usually it is a descriptive classifications. Either it is closed or open fractures. About the site of fractures, it is a proximal, middle, or distal shaft fractures. About the pattern of fractures, either it is transverse, oblique, or spiral fractures. The angulation and degree of comminution and amount of displacement, translation, and shock. Clinical features, we should take a good history. Usually there is severe pain of the child. On examination, a careful neurovascular examination should be performed. and compare to the other normal side. And if any maneuver or any reduction like splinting or traction applied, we should repeat the neurovascular examination and compare it to the normal side, and should be normal all the maneuver. Radiographic finding, we should take a standard X-ray, AP, and lateral radiograph of the entire femur, including hip and knee of the ipsilateral and contralateral side, especially the hips. As we see here in these X-rays, there is femoral shaft fractures, but we should not mess up the contralateral fracture neck femur. Always, we should take an X-ray clearing the ipsilateral neck femur also. What about the deforming forces of the surrounding musculature resulting in characteristic deformity or displacement, especially in the proximal femur? The proximal shaft, the proximal surge fractures result in flexion because of the effect of iliopsoas muscle, abduction from abductor muscle group, and external rotation by the external rotators. Treatment of pediatric shaft fractures, the age guidelines is the most important thing. Below the age of 6 months, we can go in for immediate hip spica or Pavlik harness with excellent outcome, with time to union average about 5 weeks. As you see here, this is an infant 3 weeks old, managed by immediate hip spica or Pavlik harness, and result up in a good union and good remodeling at age of 4 months. The age group between 7 months to 5 years, this is regarding to, we can take in consideration the amount of shortening at the fracture site and the amount of angulation. If the shortening less than 3 centimeters and the angulation less than 30 degrees, we can go for immediate casting in hip spike. If there is shortening more than 3 centimeters or angulation more than 30 degrees, we can first go for traction for a while, either it's skin or skeletal traction for a while, followed by the definitive treatment in hip spike. The age group 6 years to 10 years old, mostly this is routinely treated by closed or open reduction and stabilized by flexible nails. The age groups 11 years to skeletal maturity, there is a lot of options here for treatment. Usually the flexible intramedullary nails is the acceptable choice, but we can add also the plating considered for unstable pattern of fractures, and trochanteric entry nails with a smaller diameter available. It is good at good results with older children and unstable fractures. And this is allowed allow early weight pairing and can be used in larger children who could otherwise have a compromised result with flexible nail. This is an X-ray showing an MRI showing an avascular necrosis as a complication of intramedullary nail with femoral shaft fractures in a 12-year-old boy. Because this is most probably because this is a piriformis entry nail and this is injured the blood supply to the femoral head, so it ends up with avascular necrosis. What about the most common complication associated with femoral shaft fractures? Usually a neurovascular injury, like vascular injury, limb discrepancy, unacceptable angulation, rotational deformity, non-union or delayed union, compartment syndrome, and infection. The take-home message: children below 36 months with a diaphyseal femoral fracture should be evaluated for child abuse. Treatment with a Pavlik harness or hip spica is an option for infants below 6 months with a diaphyseal femoral fractures. Early spica casting or traction with delayed spica casting for children between 6 months to 5 years with a diaphyseal femoral fracture with shortening less than 2 centimeters. Flexible intramedullary nailing is an option to treat children between 5 to 11 years diagnosed with diaphyseal femoral fractures. Rigid trochanteric entry nailing, submuscular plating, flexible intramedullary nailing are treatment options for children 11 years to skeletal maturity. who are diagnosed with diaphyseal femoral fractures, but piriforms and near piriforms entry, rigid nailing are not option for treatment. There is no strong recommendation for or against removal of surgical implants for asymptomatic patients after treatment of diaphyseal femoral fractures. There is no strong recommendation for or against the use of locked versus non-locked plates for fixation of pediatric femur. There is no strong recommendation for or against physical therapy to improve functions after treatment for pediatric diaphyseal femoral fractures. Thank you.